welcome everybody. Thank you for joining us today, especially in these crazy times that we're having. I do want to let you know we are recording this webinar, so no fears. If there's something that's said, you need to go back to hear it, or you want somebody else to be able to listen to this, the recording will be available up on the AOA's website. It will be on the COVID-19 page, and we'll have a link to that later on in the webinar. Those of you that are listening in and going to be trying to get your CME for this, reminder that you need to go back to the AOA online learning platform after the webinar to fill out your post-evaluation. Also wanted to remind you that this webinar is more of a how to get started in telemedicine for those of you that have never done it. We will have more webinars coming up in the next week that will be touching on the billing and the coding, the HIPAA messages regarding this, social media, all of that is coming up as well. We do have our telemedicine guide that provides the billing and coding information that is available on our website. We do have that link again later on in the show. So I wanted to let you all know that. And as I said, any questions that you have throughout the presentation, type them into the chat box. Following Dr. Brown's presentation, he will answer as many as he can. Those that cannot be answered, we will take those back to AOA and we will get answers for you and either reach out to you directly or provide all the answers to the attendees if we feel it's something that would benefit the good of all. And I think with that, I am going to turn it over to Dr. Brown.
Thank you. Hopefully everyone can hear me okay. Raise your hand if you can't. Sorry, I can't see you, but you know, hey, we'll go from there. Well, thank you, everybody. It's quite interesting to see how many people are on this call for presentation for telemedicine. I've been presenting about telemedicine for several years now, and I don't think I've ever had this many people interested all at once. I feel like a week ago, I was just a trendy young doctor, you know, trying to push a fad, and now here we are a week later and everything has changed. So I'm hoping to get as much information as I can to you tonight. And like she said, this is being recorded. I will make the slides available to AOA. I haven't put anything that's proprietary in these slides, so you can look at them. I put lots of links in this slide, so hopefully you'll be able to use those because I know there are a lot of topics I'm going to talk about that I'm just not going to have time to give a full explanation for. So with that, we'll just keep moving forward with my presentation here. Just a little bit about my background. I'm a full-time family medicine physician. I'm practicing in the Kansas City, Missouri area. I'm in a small little town north of there called Smithville, Missouri. There's only 2 other physicians in this town with me. And I am the president-elect for the Missouri Association of Osteopathic Physicians and Surgeons, former assistant CMO for Mosaic Healthcare, and I'm former director of telemedicine for them as well. And I'll kind of talk about my experiences with those as we go through this presentation. There's a picture of me right there in the corner with my friend Mo. It turns out that when you're actually starting a telemedicine program, having a posable skeleton actually can come in handy. We actually used him a lot, putting him on the other end of our test site so that way we can know that we were, which room we were zooming into for telemedicine and things like that. So he's helped me a lot through this telemedicine journey. My telemedicine experience began actually several years ago. We created the first direct-to-consumer telemedicine program in the state of Missouri. This was long before the big national chains were in our state. I went through a lot of regulatory issues. I went from being told that if I continued what I was doing, I was going to get in trouble, to actually being appointed to committees in the state to help them regulate telemedicine within the state. We've come a long way in Missouri. We actually have a member of the Board of Healing Arts, one of our former presidents of MAOPS, David Tannehill, who sits on the Board of Healing Arts, and he actually practices telemedicine. So it's amazing how far we've come. I also trained and operated a full team of APRNs and helped them with acute care direct to consumers. We'll talk a little bit more later on about why we did that model. And then currently we're operating a practice that fully blends live visits with telemedicine visits. This is pretty cool because this is what a lot of people are doing right now. And I'm, you know, with all the pandemic stuff going on right now, with all the fears, with all the craziness that's going on in the world, to me, this has been a little bit of a silver lining for our patients, and that's our ability to give them care through telemedicine. So this slide right here is my disclaimer slide. First one I should mention is that I don't have any affiliations with any other commercial programs, any commercial societies, no drug affiliations, nothing like that. I strictly work on my own with this and work for my health system. I work for Meritas Health, also owned by North Kansas City Hospital. But this is new. Everything I'm talking about with you today has happened in the last week. There's a lot of online resource guides for telemedicine right now, and unfortunately, every single one of them is probably out of date now because things have changed so much. And so you just kind of have to keep up with what's going on. I'm going to give you some resources that have some ongoing updated lists as the rules and the guidelines change. But this is new. So my disclaimer is everything you're about to see in this presentation, I just started it 2 days ago, and I've been trying to compile this information, and we just started this new way of practicing a week ago. So everything I'm showing you is what we're doing currently, and I hope that it's helpful for you. I'm hoping by the end of this presentation that you'll have enough information to maybe even start doing a little bit of telemedicine on your clinic, or at least going to your practice administrators and talking to them about how can we do this and can we do this quickly. So previously, what I call the pre-COVID era of telemedicine, we had a lot of things that were holding people back. Number one is it was very poorly reimbursed. It was very hard for me to motivate physicians to do telemedicine when they were getting paid twice as much or 3 times as much to see a patient live in the clinic. I continued to do it. I liked it, but yes, I fully admitted that I would have made more money if I'd seen that patient in my clinic. And so that was definitely something that hindered it. There were select physicians that did telemedicine only that were able to make a living out of this because they increased the volume enough to do it. But for somebody like me in a rural health clinic, doing telemedicine just really wasn't financially viable. You also had very high technology costs. The regulations made it so that you had to use very select programs to practice telemedicine. That created only just a few of those programs, which creates a lot of, dare I say, monopolies. They're not necessarily monopolies. They do have some competition, but not enough to really drive the costs down when it comes to technology. There are diagnostic devices for telemedicine, things where you can remotely look at ears, listen to hearts. Again, very, very high cost. Just not very practical for the average family physician or any type of physician to be using at this time. Also very complex processes. Because you had to meet all these regulations, we spent 2 years before we did our first telemedicine visit in the state of Missouri, making sure that the billing was in place, the technology was in place, the security was in place, and our documentation was accurate. 2 years to get just our first telemedicine visit, and it took us 2 days to get every other physician in our system doing telemedicine with these changes that happened the last week. I really call this the wild, wild west of telemedicine right now. Things have really been opened up. Barn doors have been open. We'll see what happens in the long run here. This right here, I just show you this as this slide. You don't have to get anything out of it other than this was our process that took us 2 years to come up with just to decide if a patient was eligible to even apply to do a telemedicine encounter. We had to go through all these different steps, all these different flow charts just to make sure that they were safe and eligible for a telemedicine visit. This is one of the barriers that people had before for not doing telemedicine. So all of that changed March 17th, just a week ago from yesterday, when the Trump administration made the official announcements of expanded Medicare telehealth coverage. A direct quote from that was that CMS will temporarily pay clinicians to provide telehealth across the entire country. Many states immediately enacted emergency changes to support this as well. So telemedicine and the practice of medicine is, it is regulated on a state-by-state basis. So the states basically got their laws and their rules in line with this announcement from CMS. I'm going to read a lot of things from these announcements because I want you to feel comfortable doing this. I don't want you to think that I'm just making this up or interpreting this. So I've put some direct quotes in some of these slides so that way you can feel comfortable and you can interpret it the way you want. This one is one of the more important parts. It says clinicians can immediately bill immediately for dates of service starting March 6th. Telehealth services are paid under the physician fee schedule at the same amount as in-person services. This is something we've been fighting for years, haven't been able to get, but it's now there. Medicare coinsurance and deductibles still apply for these services. Additionally, you've been provided the flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits. What this means is that if you don't want to charge a copay, you don't have to charge a copay. And previously, we didn't have the ability to do that. So there are a lot of insurers, commercial insurers, that have matched this guideline, and a lot of them that are actually waiving copays for patients that are doing telemedicine visits. And I'll talk more about that a little bit later. Again, when you get these slides, I have right at the bottom the links so you can read the full press releases, and you can see the sources for this information. So there are a few things that were holding us back regulatory-wise with telemedicine, and I want to kind of go over those. The first one was, do they already have to be a patient of mine? It used to be that in most states, particularly in our state, you can only do telemedicine with somebody who was already one of your patients. Well, to the extent that this waiver requires that the patient have a prior established relationship with a particular practitioner, HHS has agreed to not audit to ensure that such a prior relationship existed. So essentially what the HHS is saying is that you don't have to have the patient have a prior existing relationship with you to do telemedicine. They're essentially saying we're not going to enforce this. This is kind of like decriminalizing marijuana, honestly. They actually do have a right to do this under Section 1135 of the Social Security Act, but basically what they're saying is we're not going to enforce this. You can do this with somebody you've never seen before. Where can the patient be? Prior to this, Medicare, you had to have your patient in a very specific location, like they had to be in another physician's office to do telemedicine. Now, if you'll see, it says that Medicare will make payments, and it could say that they can be in a healthcare facility and in their home is what they added. And that's the new addition there, is that you can do telehealth with the patient in their home. They can be at home. This slide right here, you don't need to take much out of it other than to know that these are all the different types of definitions of telehealth or telemedicine that Medicare uses. What we specifically are targeting are these Medicare telehealth visits, which is a telecommunication system between the provider and the patient, the provider being in one location and the patient being in another, which can now be their home. Previously, you would use special codes for billing for this. What they are saying now is that we can use our standard EMM codes that we use just as if the patient were here in our clinic. We can bill those to Medicare, and they will pay us just like they were there in our clinic, at least on the physician side of the reimbursement. It also is saying that we can do this with new patients, which is new, so you could do new patient codes as well. There are other things that Medicare does currently pay for, and I'm not going to delve into them other than to tell you that they're available right now. Medicare will pay you to do what's called a virtual check-in, which is where you just basically call a patient and decide whether or not they need to come into your office. And then there also are things called EVisits. I used to call all my telemedicine EVisits, so I apologize if I jump in between the word EVisits and telemedicine and telehealth. But they define EVisits as actually doing a virtual visit it's not synchronous with the patient. So the patient types up their problem, sends you a picture, and then later on in the day you read that, and then you send a message back to the patient saying, here's what I would do, and maybe even offer a prescription or something. You can still do that, and these are the codes that are available with it. But we're going to primarily focus on these telehealth visits with Medicare, and this is where the commercial insurers have also kind of gotten behind, at least most of them have. So what about HIPAA? This is the big deal. This is where we were having problems with our communications and our security when talking to each other. This is where we needed the big expensive program, commercial program to communicate with our patients. So effective immediately, HHS and the Office of Civil Rights will exercise enforcement discretion, and they will waive penalties for HIPAA violations against healthcare providers that serve patients in good faith through everyday communication such as FaceTime and Skype. And I apologize, I just went out there. There we go. During the COVID-19 nationwide public health emergency. What this is saying is that they will not enforce HIPAA rules if you use FaceTime or Skype. This is a big change. Now, I will tell you this. If you know some of the history behind what's required for telemedicine, to do telemedicine previously, to be HIPAA compliant, you had to do something that was called end-to-end encrypted, which means that FaceTime and Skype can't eavesdrop in on your conversation. So the only people that can see the conversation is you and the patient. FaceTime and Skype already have this kind of encryption. The reason they weren't HIPAA compliant is because Microsoft and Apple did not want to sign the required agreement with every physician in America to become HIPAA compliant, whereas the private companies did. So we were being forced to pay a lot of money to private companies giving the same service that these companies offered, but they were willing to sign that BAA. Well, that's kind of all changed just a week ago. You can use FaceTime, you can use Skype during this public health emergency. The guidelines, though, if you're going to bill for the EMM code, there is a healthcare provider fact sheet that I linked to at the bottom of this slide, but they are very clear that if you're going to drop the EMM code, the 99213s, the 99202s, it says the provider must use an interactive audio and video telecommunication system that permits real-time communication. This is something to be aware of. I was trying to push for just being able to do some phone-only conversations and still get paid for it. There is still a way in Medicare that you can do that, but they are lower paying codes. If you want to use these higher paying codes, just like you see them in person, you have to have an audio and a video telecommunication. But you can use Skype and you can use FaceTime, just like they said in that previous slide. This is a reminder to remind you that medical licensure is a state issue. So your license comes to you from your state. And so you need to know what the rules are and what the guidelines are within your state for telemedicine. But most states are changing, and most states are making it so that these changes with Medicare will also apply within your state. I'm going to give you a case study from Missouri, since I practice in Missouri. I also am familiar with Kansas, and they have mirrored this almost exactly. But basically, Missouri Medicaid has chosen to cover telemedicine, so we can do this with Medicaid patients. They have waived the need for us to establish a relationship prior to telemedicine. We showed that Medicare waived that as well, but our state had a separate law, meaning that I had to see the patient first before I could ever do a telemedicine visit. They also waived the need to establish a relationship with the patient prior to prescribing medications to a patient. This is very interesting because that includes controlled substances. Previously, they made it so that you could not prescribe medications using telemedicine unless you had an established relationship with that patient. So it would allow people to do consultations where they didn't prescribe medicine if they hadn't seen them before, but they could not prescribe a medication. That has all changed. They also waived the requirement. This one right here is probably causing no small amount of heartburn among our state medical boards, but they have waived the requirement that you be licensed in the state of Missouri to perform telemedicine in Missouri. So all of you that are not in Missouri, if you would like to perform telemedicine in my state, you are now able to do so as long as you're licensed in your state. Previously, telemedicine laws were all based upon where the patient was located. And so the statement was, medicine is practiced where the patient is located. So for me, I live on the border here of Missouri and Kansas. So I carry a Missouri and a Kansas license. And I did that because if someone in Kansas were to do a telemedicine visit with me, like a worker for our health system that lives in Kansas, I could not do a telemedicine visit with them when they were at home living in Kansas. Now I can, because Kansas also waived this law. Previously, though, you'd have to be licensed in that state. So you'd have these professional telemedicine doctors that would be getting licenses in 20 states, so they could practice in 20 states. A lot of states have fallen in line with this. Missouri has, Kansas has. I know a lot of other states have. This resource right here, this is the American, I think it's the Occupational Therapists Association. They were the most complete list I could find that was updated as of today, that goes state by state and has links to all the different waivers, the different announcements that have been related to COVID-19, and they have all the telemedicine announcements and the changes to laws in your state. So if you go to this link, you should be able to look up your state and see what kind of changes have been made within your state. Some states did not even have that much regulation, so they didn't have to worry about it. Other states like Missouri was actually very highly regulated, and all those regulations have now been waived. So what about commercial insurance? This right here is also another link that I found for you. Again, I put caveats on all this information. It changes daily. And so I should say it changes hourly. I think many of you can relate to that. I used to say I take it day by day. I think most of you are agreeing with me when I say I take it hour by hour. This is the American Health Insurance Organization. They have a list of every major health insurer and the changes that they have made according to COVID-19 and what kind of changes they have made. As you will see, one of my major insurers, Blue Cross and Blue Shield of Kansas City, is waiving fees for urgent and sick virtual care visits. They actually are waiving the copays when patients do telemedicine with me, so that way they can do these telemedicine visits. They're trying to encourage these. I know the Kansas governor, when she released her telemedicine statement, she actually added in a line there stating that they encouraged providers to use telemedicine. They weren't just trying to make it easy for us to use. They were trying to tell us to do telemedicine. So after all this whirlwind of changes that I've just gone over, how am I actually putting this together now in my clinic today? So since 3/19, which was 2 days after we got this information, I'm very proud to say the administration of my hospital has been very, very fast moving. I've been very proud of them. They've been trying to push things through our legal, through our coding, and our CEO, as well as our vice president of our clinics, did an amazing job. And literally 2 days after these announcements, they gave all of us the go-ahead to do telemedicine. Very proud of how quickly they've responded to this. They also have increased our licensures with our commercial telemedicine provider. We actually had a license with one of those expensive telemedicine providing services. So they're increasing our ability to use services there. But until we get those actually running and operational for more of our providers, we've all been authorized to be able to use the private video conferencing technology that we mentioned earlier, that HIPAA has chosen, or that HSS has chosen not to enforce any HIPAA standards on. I will tell you, this has been widely accepted among our providers. My guess is the fact that there's over 500 people on this call says that all of you are also eager, or at least interested, in how you can use this service with your patients. Most of our physicians were actually already requesting this, weeks ago, as COVID got, more and more information in the news, and we were looking for ways to keep patients out of our clinic. This is a workflow that I created. This is a personal workflow. You are welcome to use it. It is a very simple workflow that I made that you can have your staff help decide when to schedule someone through a telehealth or a telemedicine visit. You remember that really complex slide that I had previously? This is my simplified slide. In my clinic, there are 2 ways that a patient can get on my schedule. They can call for an appointment, or they can schedule online. If they call for an appointment, my first question my staff will ask is, does the patient have cold symptoms? If they have cold symptoms, it's an automatic hard stop. I will only see them by telemedicine. This is actually a policy we have going throughout our system. We are trying to keep our colds or coughs out of our clinics. We do have a respiratory clinic that we will refer them to if they need to be seen in person, but I put all of them on as a telemedicine visit on my schedule, just like they'd be scheduled to see me in person, except they're going to be marked with their chief complaint as tele, and then what their chief complaint is. So I can tell that, okay, that one's here for telemedicine, that one's here in person. If they don't have cold symptoms, then I ask them to offer every patient a telemedicine visit. I'm okay with letting the patient try to make that decision first for them. I do have a caveat. I do have a way for me to check that. But if they would like to do it by telemedicine, then I'm trying to get them in by telemedicine. So they'll put them on my schedule. Another way that patients can get on my schedule is by scheduling online. So the key to this is that I review my schedule every morning. And if I see a patient on my schedule and I think that they could be a telemedicine visit, then I ask my nurses to call that patient and try to switch them over to telemedicine. If the patient does not want to go to see me by telemedicine, then they can come back in and see me in the office. But if they do, they change the chief complaint to telehealth, and then put the chief complaint in there. This process makes it so that I can emphasize and get as many patients not coming into my clinic and being treated by telemedicine, so I can diminish their exposure to a potential COVID exposure. And that's what this slide says. The physician does control this schedule, so if you're going to use this workflow, you've got to be able to look over your schedule frequently. You can't just, take the next patient in there. You need to sit down at the beginning of your morning and decide who can be seen by telemedicine and who can't. A little bit of tips that I found in doing this: I've assigned a staff member to be my telemedicine check-in person. You pick your youngest staff member, the one that's always on her phone all the time. She's going to be perfect for that. And I have a wonderful staff member who is great, and she just jumped on this. And so I gave her a laptop, and I let her do the check-in process. So what she does is, if they want to be seen by FaceTime, or they want to be seen by Skype, she pulls them up on Skype on her laptop, and she does the check-in process with them that way. What's great about this is it makes sure the technology is working before they get to you. So we make sure the microphone is already working. We make sure that their volume's okay, and then you don't have to worry about that when you're actually visiting with them. It also controls our wait time. So she'll do that check-in with them, and she'll tell them, Dr. Brown will be about 5 minutes. He'll be about 10 minutes. And then she actually turns the patient to, and our health EHR, it turns them to green, meaning that they're actually in the clinic. So she checks them in, and on my schedule, it looks like the patient's actually here in my clinic. That is a signal to me to know that they are fully checked in, and I can just contact them by FaceTime or Skype, and my nurse just usually writes on a sticky note and puts it on their charge slip or something. Here's how they want to contact you, and that's how I contact them. This is another workflow that you're welcome to use. This is the workflow that I just described to you, involving your access rep and your patient. And you can kind of go through that, and you can see if it works for you. If it doesn't work for you, great. Again, we'll make these slides available, and we'll make it so that you can use this yourself. So what technologies can you use right now? What technologies am I using? Right now, the big ones have been FaceTime, Skype, Facebook Messenger, and Google Hangouts. And I'm going to go over all of these with you. I don't mind using all these different ones because different patients are comfortable with different technology. I think they're all fairly easy to use. The first one is FaceTime. So don't do what some of my colleagues did when they first got ability to do this. I had some colleagues, they had a whole group, and they went out and bought everybody a brand new iPhone because they wanted to be able to FaceTime with everyone, but they didn't want to use their personal phones. So everybody got a separate iPhone. So now they all have two iPhones that they have to carry around. And if that's not going to lead to burnout, I don't know what will. But the thing is that you can set up your iPhone pretty easily to make it look like you're calling from your work email. And you can do that on your personal iPhone if you want to. I don't have time to do that in this presentation, but there's a link here that you can go to that will show you have to do two things. One, you have to associate your work email with your Apple ID accounts. And two, you have to change your caller ID on your FaceTime settings after doing that. So what will happen after you associate your work email with your Apple ID account, you'll be able to go into your FaceTime settings under your normal settings on your iPhone, and you'll be able to select your work email account as your caller ID. So anytime you use FaceTime from your phone, your iPad, or your MacBook, it will look like you're calling from your work email account. And then you don't have to worry about patients getting your personal phone if you don't want to give it to them. I'm very comfortable with my patients having my email. I've given it to them for years. It's been a great way for them to access me. I learn a lot of things by making it so my patients can just send me notes about what's going on in my clinic and how they're struggling trying to get something done or something like that. It's been very helpful for me. Something I would encourage you to do. As you start doing more telemedicine, you'll learn that it's okay to let patients contact you a little easier. It makes your life easier. If you're using Skype, Skype is much easier to set up with a work email than FaceTime is. For Skype, all you do is when you're logging into Skype, you just click sign in or create. It will take you to the Microsoft Create an Account, hit create one, use your work email. They will send you an email to your work email. You'll verify that, and then you're good to go. And then when you Skype with people, you'll have your own work account. I actually put my nice little photo of me in a white coat. The irony of this is that I hardly ever wear my white coat in person, so I wear my white coat more doing telemedicine than I do when I'm seeing my patients in person. Facebook Messenger is another thing that turns out is a lot more popular than I thought it was going to be with my patients, especially my older patients. Turns out this is a way that a lot of people like to use video with their grandparents. So grandparents like to see their grandkids. They use Facebook Messenger and they use video this way. So remember, if you're going to use Facebook Messenger, that you're using Facebook Messenger. You're not using Facebook Live. We don't want to broadcast patient visits on social media. That would actually probably still be a HIPAA violation, and I'm sure they would have a problem with that. It does work easier if you have them added as friends. I teach an entire lecture on social media and physicians with social media, and I always in the end recommend that people have a professional social media account and a personal email account or social media account. I know some people have different views on this. This has just worked well for me, and so I do have a professional account. So I just add the patient as a friend, and then I connect with them by Facebook Messenger. You can do it without adding them as a friend, but it's kind of difficult to find them. And this is another thing that I have my front desk staff do. I tell them to send a friend request to my professional account, and that way they're all set up for me to do Facebook Messenger with them. When you're using Facebook Messenger, you just click on that little Messenger button up there, and then you click on this little video when you're in chat. This is me on my professional account trying to chat with me on my personal account, which actually did work. It was kind of weird, the feedback on it, but it worked. So some best use ideas. I recommend using your work email to create accounts, particularly if you're worried about them seeing your personal cell phone number when you're doing FaceTime. Another recommendation that some people have used is creating dummy accounts, like a fake Gmail account associated with it. I do not recommend that, but it's something you could do. Make sure you set an autoresponder so that if people email that account, they get an email back that says, this account is not monitored, please don't email us. And then this is the only time you're gonna see me endorse any product right now. And the only reason I'm endorsing Apple products is because I've been doing telemedicine for years, and I will tell you hands down, when the person on the other end has an Apple product, I have way less problems than any other kind of product. They just have the built-in microphone, they have the built-in camera, and they turn on automatically for you. When you're using a Windows-based device, you gotta make sure the volume's on the speakers, you gotta make sure the camera's on, you gotta make sure they're both not on mute, you've got to, and then you just make sure that the volume and settings are right. You just have to do half those things with an Apple product. So for me, what's worked best with doing this is I use a MacBook, or like you do a MacBook Air, you could do an iPad, and that is my device for telemedicine. What makes that nice is I don't have to worry about switching back and forth between my personal phone or something. Do I have the settings right? Do I not have them right? I just have a MacBook that I use when I'm at work. The cool thing about that is that I can do FaceTime on it, I can do Skype on it, I can do FaceTime Messenger, and I can do Google Hangouts. And on a Windows-based laptop, you can't do the FaceTime, so you can't do all of them on one device. So my MacBook, my personal MacBook, has now been turned into my telemedicine device, and I just use it at work, and that's what I use it for now. And it works really well. This is a really cool slide. This is a picture of my schedule yesterday morning. While I was making these slides, I just took a quick snapshot of it. This has been my dream for years, and it's sadly taken a national pandemic for it to occur, but this is fully integrated medicine. Sometimes my patients are telemedicine, sometimes my patients are in person. As you'll see, about every third patient yesterday morning I was doing telemedicine. My goal is to make it every other, because to me this is still too many patients coming in, but you will see that there are things that I needed to do to have patients come in. This patient needed a med refill and FMLA paperwork, and they needed it filled out today, so to get it filled out we had them come in. This patient was a chest pain follow-up, and they needed lab drawn, and so they needed to be seen quickly, so we saw them. This patient was an eczema case, easily treated by telemedicine. This patient actually added onto the schedule last minute. Otherwise, I would have done them by telemedicine. That's why I said we could have done more here. This was a mental health medication follow-up. This patient had a left earache, so we brought her in so we could see it. This one was a UTI. I will tell you about UTIs. I always get this question: how can you treat a UTI by telemedicine without it getting a UA? I strongly recommend that if you're questioning whether or not you can treat a UTI by telemedicine, think about two things. One, do you treat them on Friday night? And we'll talk about that more later, because I will tell you, I don't make a woman wait all weekend to get a UA if she's got UTI symptoms. I help treat her. And two, read the up-to-date article on how sensitive and specific UAs are compared to the history. And I will tell you, one is more sensitive and one is more specific than the other, and it's not the UA. And then this is a telemedicine follow-up, and this was just a follow-up, and I can't even remember what it was for. This last one was actually a walk-in, and she actually had a very large abscess that ended up having to go to the ER, so she was very appropriate for coming in, and obviously that wouldn't have worked very well by telemedicine. Some scheduling tips. Make sure you train your staff to suggest telemedicine to your patients. I encourage this. Again, I'm not at the point where I'm trying to sell telemedicine anymore. I'm trying to keep patients out of your office and getting exposed to potential viruses that we don't want them to have. I encourage that you talk to your patients about follow-ups and encourage them to be done by telemedicine. When I see patients in clinic now and I want to follow up with them, I usually say, hey, I'm going to have you follow up with that. I had a blood pressure patient come in. I verified that they had a nice Omron blood pressure cuff at home. I scheduled my follow-up with that patient to follow up with me in a week. With his blood pressure monitor in hand. I'm going to have him check his blood pressure in front of me, show me what the blood pressure is, and we're going to see how his blood pressure is doing at home. If that doesn't work and it looks inaccurate, well then, hey, we'll bring him in and have my nurses check it. But try to think outside the box here. Think of other ways that you can treat these patients without having to bring them in with potential exposures. And consider workflow for labs and things like that. There may be times where you really do need that UA, because there are definitely times where you need a UA. If it's a recurrent UA, if it's in a male, if they're not responding to antibiotics or something like that. But you could consider a workflow where they just come in, get that urinalysis, go home and do a telemedicine visit with you. I mean, there's options here. See if you can find something that works with your staff. Think outside the box. Some technical tips. I always recommend that when you're doing telemedicine, have a headset with a microphone nearby, just in case something happens to your phone, something happens to your computer. You can just plug that headset and microphone in. Certain types of programs, and sometimes you get weird feedback. That standard little white pair of headphones that comes with an iPhone works really good because it has headsets and it has a microphone built into that volume control, and it works really good. Remember at all times that you have the contact information from the patient, or at least you should. So if you're getting the video up and you can't get the patient to get their speakers to work or something like that, you can always call them on your phone, put that on speakerphone, and now you've got video and audio going on the same time. You're just doing two different devices. And then always make sure that you don't proceed until you've ensured that the patient can see and hear you properly. The first thing I always say with the patient when they come online is I say, hey, Mrs. Smith, can you hear me okay? And I wait for them to respond and tell me that. And then I can see if I can hear them too. But don't keep moving forward with your visit till you know that they can hear you okay and they've adjusted their microphone. Again, this is where it's nice to have a staff member contact them first by the method that you're going to be using, so that way it's all set up correctly before you even get to them. Also, remember your background. So right now, I'm in a clinic room. I typically like to do these visits in my clinic room. Sometimes I do them in my office, but I have to be very careful about what's in my background in my office. If you've got a whiteboard there with a list of patients to call back or something like that, you're going to be breaking HIPAA no matter what method of technology you're using. So be very careful with your background. Remember what's in your background. And again, if you're worried about that, the safest place to do a visit is throw your laptop inside a patient room where you do a normal patient visit. Then it's going to be in a safe environment. And you can even have your nurse say, hey, go to room 3, your laptop's there, and you're ready for that patient. These are just some really general tips. I always joke about this one. Make sure you've got proper grooming, at least from the waist up. Below your waist with telemedicine, who cares? Unless you stand up. Proper lighting. Make sure you've got lighting in front of you. In this room right here, unfortunately, I've got one above me, which with my head creates a great little reflection. Not much way to get over that. I did shoot a commercial one time, and the lady was trying to sell me on this little cream that I could put on my head and to get rid of all my shine. And I probably should have invested in that, a lot of it, since I'm doing a lot more telemedicine now. Try to eliminate distractions, dogs barking, phones ringing. Avoid shiny jewelry, because that actually will create glares on the screen for the patient. If you've got a very shiny brooch or necklace, that could get in the way. Patterns don't work very well with cameras on phones and things and on your computers. So if you're wearing plaid or some kind of pattern, that can look really funky on a computer screen. So flat colors work really good. And just try to keep your workspace neat and clean if you're using it on your home workspace. Some service tips when doing telemedicine. Remember, telemedicine tends to be where bedside manner with the patients is even more critical. Opinions are made in the first few seconds, and so it's even more important. When we were training physicians to do telemedicine, the patient or the physicians that had trouble communicating with patients in person had way more trouble communicating with them in telemedicine. Speak clearly, enunciate carefully. Don't speak as fast as I've been speaking to you during this lecture. I apologize to all of you that I've been concerned with that. I'm just trying to get this information in. I know you'll be able to review it later. Help focus the visit. What are you most concerned about? Be sure to address that concern before you're done with the visit. Also, be sure to summarize what the patient says. In telemedicine, this is very important because, again, you might not be hearing them correctly because of the technology. So it's always very important to repeat. Okay, so what you're saying is you have had this cough for the last 3 days. Is that correct? Things like that. And then, of course, as always, even with them in person, really try to avoid medical terminology jargon with patients. Use the word heart instead of cardiac, throwing up instead of vomiting, stomach versus abdomen, those kind of things. Very important with your communication. I used to teach a whole 6 or 7 slides on how do you treat this by telemedicine, how do you treat a UTI by telemedicine, how do you treat a cough by telemedicine. I narrowed it all down to what I call the EVisit Rule law, and again, I'm using the word eVisit incorrectly, but I narrowed it down to what would I do Friday night at 11 p.m. All of you on this phone call have been practicing telemedicine for a very long time. You've been doing it with your telephone, which is why I'd like Medicare to reimburse that just as equally as telemedicine. But you're practicing telemedicine. When that person calls you at 11 p.m. on a Friday night, how would you treat them then? What would you do with that scenario? These are ways that you can practice telemedicine. This answers a lot of questions. What would I do if I needed a lab test Friday night at 11 p.m.? What would I do if they needed a medication Friday night at 11 p.m.? I'd probably call it in for them. Or maybe I'd say, let's wait a few days. Or I do this or I do that. You know, this really helps. What if the patient's angry or upset? What would I do Friday night? What do I do if they need a higher level of care? Well, on Friday night, I'd send them to a higher level of care. These are, to me, helps us answer the ways that we do different caring. So let's go back to our telemedicine concerns that we talked about at the very beginning of this lecture. So we talked about how telemedicine wasn't very properly reimbursed. Well, now with these changes, we see that we're being reimbursed appropriately. We're being reimbursed just like they were inpatients. What about high technology costs? Well, you can use what you own now. You can use your cell phone. You can use a laptop. You can use Skype, FaceTime, Facebook Messenger. They're all free. Try to use the technology that you already have. And that's what they've been trying to do with waiving these rules and these regulations. What about those complex processes? Well, now with billing, you're just using the same code you already were using. With the technology and security, they've waived those requirements to make it easier. With documentation, you should be documenting the same as if you saw the patient in person. You can document, by the way, a physical exam with telemedicine. You can document that you don't see a rash on their hand or you do see a rash. You can document that they're breathing correctly. You can document that they don't have slurred speech. So there are things that you can do through telemedicine. You can document that they can move their hands. You can document that they've got a big red rash or something like that. So there are physical exam findings that you can document through telemedicine, and you should document those. But I will give a caveat. If you're using templates and all of your templates say that the patient's lungs were clear, you probably should change your templates because that's going to look really bad on an audit or a review if you say the patient's lungs were clear on a telemedicine visit, unless you have a nice fancy Bluetooth stethoscope that they have on the other end. So my take-homes for all of this is, one, get your coders on board with you. Talk to your coders. Make sure that they read the up-to-date information. If they're giving you any information that is more than a week old, then it's probably not up to date. So if you're having a hard time with them, have them go back to their societies, have them go back and look at what's going on right now, just this last week, so that you can get them on board. Get your IT departments on board. If you're in a small clinic or a private practice, your IT department might be you. So get you on board, get you willing to use this technology. And then my last take home is get moving now. This is something that is keeping patients from being exposed to a potentially lethal in some of our elderly population. And so we need to do our best to try to keep them from getting exposed while still being able to give them high quality care. I'm very proud to be an osteopathic physician during this day and age. I think back on A.T. Still and how when he started osteopathic medicine, he was innovative. He was doing something different that wasn't being practiced at the time. And I think this is just another way that we as osteopathic physicians can take something, we can be innovative, and we can do something that we haven't done before, and we can really help a lot of patients out. And so with that, I'll move on to any questions. And then I think we have some additional slides from the AOA staff, but I didn't know if we want to do questions first or if you wanted to go over that first, Cynthia.
Thank you for a great presentation. We can go to the questions first. And I just want to remind everybody that maybe didn't hear when we started out that this webinar was to cover more how to start in telemedicine. We will be having more webinars coming up that will cover more of your billing and coding type questions. And also that a lot of the questions that you were asking in the chat box are answered in the guidebook that is available on the AOA's website. But I will go into the chat box. Okay, first one, I think one of my main questions, is there a scope of practice limitation right now? What if I'm not board certified in primary care? Is there any role for physicians such as anesthesiologists, radiologists, pathologists, surgical subspecialists?
So I'm not on a board of healing arts, and I may or may not practice in your state, but here's what I would say to that question. The standard of care is and has always been the standard of care. And so when you are doing telemedicine, you are expected to give that patient the same outcomes over a telemedicine visit as if they had seen you in person. So if you can't provide that standard of care, then you should not be providing that standard of care. And that's how I would answer that question.
Okay, let's see. Difficult in the past to get clarification from insurance company, whether they cover telehealth, and frequent have to put the responsibility back on the patient. Any recommendations on that?
Definitely check out that link that I put in there, because there were several pages of what different insurers are doing. I would say though that, this is where you're going to have your biller or your coder help you out to let you know who's going to be covered. I think I glossed over it, but we have found one carrier that's giving us a little bit of trouble right now, and that's Cigna. That may have changed in the last 2 days. I don't know. But every other carrier, for the most part, is doing their part with this COVID and trying to make it easy for them to get coverage. So I would definitely check with them. There's always caveats to this. And so you're going to have to make those decisions with your biller or your coder. But again, like I said, make sure that they are up to date. They are not going back to you with an answer from something that they got trained in 2 weeks ago. It needs to be something that they've been trained in the last 7 days.
Okay. How do you do telehealth for a new patient visit in terms of verification of insurance and all the paperwork needed prior to?
That's a tough one. I'll be honest with you. I don't have a good administrative answer to that right now. What I've asked my staff to do, and I'll be frankly honest with you, I haven't had anyone ask me to do this yet. That's a new patient. I just went over that's been waived and you could do it. My personal recommendation to my staff, and I haven't gotten this approved yet from administration, is that we just email them all the paperwork and they email it back to us, with a copy of their driver's license if they'd like to do that. Obviously, you'd have to give a caveat to say that, email secure on my end. It might not be on yours. But again, I'm just making things up here when it comes to that. We haven't run across it yet. That is an interesting question that I'm hoping to get more answers to. And we'll just have to leave it at that.
Okay. Did I hear that right? You cannot bill a 99213 with just an audio telehealth visit.
That is correct. So I went back when I saw that too. I was upset as well, and so I went back to our CMIO and also to our coders. If you go back on my slides, that was a direct quote that it has to be audio and video, and that comes from the frequently asked questions portion of the CMS announcement that happened on the 17th. So as of right now, yes, we're reading it as you have to do audio and video for your EMM codes at least. And I frankly don't agree with that, but that's just where we're at right now.
Right. Okay. Some of the laws that are waived, prescribing medications for new patients, is this only during this health emergency?
It is in the state of Missouri, but remember, those laws are going to be based on your state. Some states already had telemedicine laws where you couldn't prescribe online or you had to follow X, Y, Z. So it depends on your state as far as that goes. In my state, I can. They are specific that it's during this emergency. I will be very interested. I mean, these are some barn doors that have been opened, and I'll be very interested if any of them ever close. They may not. I don't know. I will tell you this: it's shown how unnecessary some regulations are, and I know that some people will cringe a lot when I say that, but it does. And I think you're going to have a lot of people. You're going to have a lot of congressmen and senators that are now doing telemedicine with their patients that are going to go back to their lawmaking and wonder why we can't do it that way anymore if we take it away. So it'll be interesting to see.
Okay. Have you heard anything regarding the waiving of the copay? Does that mean that the insurers are going to pay the physician what the patient would have normally paid for the copay?
I don't fully know the answer to that, and that's going to be a commercial provider, case-by-case basis. So I don't know the answer to that. It may be with some insurers that, yeah, they are. It may be with most that it's probably going to be what they mean by waiving the copay, meaning that you don't have to charge it. A lot of people have agreements with their carriers that I have to charge a copay. I can't waive that copay. That's part of my agreement to see their patients. So when they say you can waive it, it just means you don't have to get your money from it. So I don't know the answer. It's going to be a case-by-case basis there. This is why you got to work with your billers or coders. I will tell you this, though. your staff member can take the copay over the phone. You can bill for it. So what we've been doing with a lot of patients is we tell them, one, we're going to send you a bill for the copay, or two, you can give us your credit card information over the phone now. We'll charge you for your copay. If it gets waived, we'll just get it reimbursed.
Okay. There still seems to be a lot of confusion regarding just a basic telephone versus telehealth, and are they the same thing? Can they be used interchangeably?
The answer is, if you want to use those EMN codes right now, and you can read through it and make your own interpretation, but we've interpreted it that you have to have a video and an audio. It doesn't say how long. I mean, I guess if you get the video working for about 2 seconds, you could try to fudge that. I don't know. I will tell you, going back to the standard of care, I feel that if I can provide the standard of care with a telephone, I should get paid for the same standard of care as if I had them in my clinic or if I had them by video. But that's my own personal opinion. We have to, work with rules and regulations here.
Right. Okay. Was that this is Mike Devine define video to include. Okay, so sorry, I'm trying to go through all these. Some people saying that the existing telephone codes do not reimburse very well.
That's absolutely correct, and it's why we couldn't get people to do telemedicine. That's why this waiver from the government was such a big deal, because what they were saying is Medicare's going to pay at the levels of an inpatient care, and that's why you've got so many more people adopting this. And I agree with you. I think I think I should get paid the same for the level of care I give, not for how I give the care. Mm-hmm. But again, my opinion, and that's why we've had a hard time getting people to do telemedicine, and that's why the people that you saw doing telemedicine before this, like myself, were making money off of it by doing it in bulk. That's why we trained a nurse practitioner team to do telemedicine instead of physicians in my last position, was because it wasn't paying enough to have a bunch of physicians do telemedicine when nurse practitioners could do it cheaper for the reimbursement we were being given. But again, that was a week ago, and this is today.
Okay. All right. Do we need to write up a SOAP note to be included with the telehealth patient note?
Well, I guess it depends on your EHR, but to me, it's one and the same. So, I mean, I write a SOAP note for my telehealth visit. I write a SOAP note for my patient in clinic. The only difference is I document that I did the telehealth one. I started out by saying this visit was done by telehealth, and the patient agreed to do it. That was it.
I'm a specialist. Do you feel that I'm at risk of not getting reimbursed by doing telemedicine?
Again, I'm going to refer you to your biller or coder on that. I will tell you this, my specialists are eating it up. I thought I was doing a really good job with telemedicine until I talked to one of our neurologists last night who mentioned she'd done 6 visits to my 3 that we'd done that morning. So apparently I'm behind the times there.
Okay. Can we use Google Duo to connect Apple to other devices for telemedicine? I don't know what that is.
I'm not familiar with Google Duo.
Okay, all right. Is it a recommendation then to use time-based billing for telemedicine?
I'm having fights with my coders on this one. You can if you want, but that doesn't pay very well. And again, I don't bill when someone comes in with me for a sinus infection. I don't bill by time because I'm not going to get paid that much. I'm going to get paid better if I don't. I will tell you this, there's no requirement. You can still bill by time and you will have to document it accordingly. My recommendation though is bill the same way you normally bill.
Okay. What do you feel the average duration of your typical telemedicine visit is?
Just a few. It depends on what they're being seen for, but I'd say it's no more than my inpatient visit. In fact, I'd say it's probably less. I don't know that the video encounter makes it just a little less comfortable, so you're doing a little less chit-chatting that you normally do. So I'd say it's probably less time. But the actual diagnosis, exam, history part, that obviously is taking about the same amount of time.
Okay. This was my first week at telemedicine. Patients are never alone. And before hanging up, I get, while we have you, my wife has had a cough for 4 days. Is this always going to be the case?
It's the same. So I get these comparisons of, telehealth to inpatient visits a lot, and I wonder the difference. So I get the same thing that happens when they both come into my clinic. I treat it the same way I do in clinic, and you just learn to treat it appropriately. You say, Mrs. Smith, I would love to help you with that. Why don't I get my staff to schedule a telehealth visit, and we'll do that, and then get them to schedule a telehealth visit with her. You already know they have the connection. But it's up to you. If you want to be nice and just treat it for free, you're welcome to do that. I explain to patients that I'd be happy to treat you. I just need to get you on my schedule. Sometimes I'll use the cop out that, you know what, I don't have your chart pulled up right now because I only have your husband's pulled up. But if you schedule a telehealth visit, then I can get your chart pulled up and we can do it that way. I mean, you can try something, just you're going to have to use your own judgment on that. But what would you do in an inpatient setting or a patient setting when they're in your office?
Okay. How do you handle vital signs with telemedicine?
I get this question too. How do you do a physical exam with telemedicine? How do you check their lungs with telemedicine? I get these at every presentation. The answer is, well, do you need the vital signs? If you do, then maybe they should be in your office. If you don't need the vital signs, then proceed with how you would without the vital signs. We go back to my EVisit rule of law. What would you do Friday night at 9 p.m. or 11 p.m. when the patient calls you? Treat them accordingly. If you're treating something that, the vital signs make a critical difference, then maybe they should be in your clinic. If they don't, then you don't have to worry about it. But I'll tell you this, if the patient's breathing and talking to you, then we know that they don't have a respiratory problem. If the patient is blinking, then we know their pulse is doing good. There's things that you can do without getting a vital sign. And those of you that have been in practice for a very long time have already figured this out. The people I struggle with more with telemedicine are the new doctors freshly out. They're good with the technology, but they're not comfortable treating a patient without all the information. But I find our older, more seasoned doctors do a really good job with telemedicine because they're much more comfortable treating the patient and how they look and their appearance. I will tell you this as my example I gave earlier. If you want to treat blood pressure, have them bring their blood pressure cuff. There's some decent studies that show that home blood pressures are more accurate than ones in your clinic anyways.
Okay, those of you that have your hand raised, you've got to type your questions into the chat box to get answered. Just reminding you. Okay, so how do I bill if I see a patient on telehealth or telemedicine and then you decide they need to come in?
I don't know the answer to that one. That's a really good question, and that's one that I definitely want to look into. I will tell you this, what I would most likely do is I would have them come in and I would just bill for that visit there. I feel like I remember reading somewhere that if you send them on, then you can't bill for it, but don't quote me on that, please. I haven't looked too much into that. Great, excellent question. But if I'm going to send them in to come and see me, then I'm going to capture that code anyways.
Okay, let's see. Very smooth video, don't require an app, just a web browser, works with all cell phones. I'm not quite sure what that is.
I think a lot of people are answering questions for other people, which I really appreciate, by the way.
Lung exam aside for no dyspnea. You don't have a stethoscope. Can we do a nursing home visit, telemedicine?
That's one you're going to have to check with your billers and your coders. My guess is that, a lot of, regulations have been changed in that area. Again, they were trying to be very thorough with a lot of these changes to make it so that we would be encouraged to do telemedicine. So check with your billers, check with your coders. Your nursing homes are going to have directors and things like that maybe you can, unless you're the director, that you can figure it out. But I don't know the answer to that one.
All right. A lot of thank yous for an awesome presentation.
Someone asked if you can use Android for a video call, and that's perfectly, I would assume that would be okay. What they're discouraging is social media videos. So they don't want you doing things like TikTok or, FaceTime Live, those kind of things. Yeah. Again, the direct word was in good faith. So, make sure the way you're communicating is in good faith. Someone asked what legal software we're using for telemedicine. We have a subscription with American Well, and that's who we use for that. I will tell you though, no commercial program is as easy as FaceTime or something like that with your patients. I wish they could get to that point. There are some that are very easy, but none of them are as easy as that. So it's really nice to do that. Someone asked, what about Zoom? Zoom's actually kind of an interesting scenario. I have heard that if you contact Zoom, you can get a BAA, and then you can actually make it completely HIPAA compliant as well. But yeah, you can use Zoom right now, because that would be a private. Now, obviously not a Zoom webinar like we're doing right now, but a one-on-one would be fine.
Can you advance the slides to the platforms that the AOA has?
Sure. Someone asked a question about pain medicine and controlled substance fee telemedicine. That's going to be based on your state. In the state of Missouri, we have a BNDD, so we have to follow their rules as well. But they have waived the regulations and allowed us to do it within the state of Missouri. I can't answer controlled substances for your state, though. You got to figure it out on your state.
Okay, and while Dr. Brown is moving the slides to show you what some of the resources the AOA has have as far as platforms that we've go to the next one. Yeah, okay, so these are two companies that we've developed relationships with that have the remote monitoring, and then the other one that has the free video consultations. So those are the links there. But a few more questions. What happens when the weather causes a glitch and internet drops out and you have to finish, even if the video never started, by audio?
Great question. I don't know the answer to that. We've only been doing this for a week and haven't run across it yet. I would say you're going to have to leave that up to you and your practice administration to decide, what it means by audio and telecommunication, because obviously audio and video, because they never put a time limit on that. So kind of up to you as to decide what you want to do. You can always drop back to the original telemedicine codes if you're just doing telemedicine only. They don't reimburse worth anything. I think they're pretty poor reimbursement, but you can always drop back to one of those codes.
Right. Okay, I specialize in OMT, also family practice certified, but I could see being able to have patients demonstrate range of motion, position of ease, and exercise and relieving activities. Please comment or advise.
Yeah, you could definitely do those kind of things.
Okay. Once this COVID-19 passes, are there restrictions for telemedicine going back into effect? And who knows? I don't think any of us know that at this point.
Yeah, and tell me when that's going to happen too.
Exactly. And
I don't know the answer to that one either.
Right. Do we just leave the physical exam section empty of telephone only?
You can if you want to, but again, like I said earlier in the presentation, there are things you can do by telemedicine, and it's by one of the providers said earlier. You can definitely do different range of motions and things. Someone asked about where does the physician have to be located? There's no rules or guidelines on that. So you can be home. I mean, I don't see if it makes a difference, honestly. My caveat is if you're at home, remember your background, remember your HIPAA compliance and try to be professional.
Yeah, and I know you mentioned it, and I think the big thing is there's so much changing minute by minute with all of this that, what one insurer is doing at the moment, by tomorrow morning, they could be doing something different.
Absolutely. Clarification about the physical exam. I guess the person wanted to know if it was telephone only. It's up to you. Just leave it blank. Remember, if you're billing a 99213, you only need 2 out of 3 elements, so you don't have to have a physical exam. You can bill on your history and you can bill on your decision making.
Right. Are we limited?
But again, I should caveat that though. Remember, for telephone only, you can't bill the 99213s yet, so you're going to have to use a telephone only code anyways.
Right. And the limits to billing a certain number of visits in a certain period of time?
Don't know the answer to that question. I have not seen anybody putting a restriction on that at this point. I would think that, right now the intent is that we keep people out of our offices. But again, I don't know the answers to that.
Right. Does the visit have to be recorded and saved?
I would hope not. I've never recorded one or saved it ever. And I think my patients would prefer that it's not. In fact, I would think, that's just me though.
Then there was a question as far as if a patient tapes the visit.
I would refer to your hospital's policy on that too. I get patients that come into my clinic live, set down their phone, and want to record that visit. You're gonna have to decide how you want to do that.
There are state laws too.
What your policy is on that. So, in the state of Missouri, you only need one person's permission to record stuff. So legally, can they do that? Sure, but they can do that when they walk into my clinic as well.
Right.
Someone asked about how you do pill counts by medicine, or have you done pill counts by medicine? The answer is no, I don't do pill counts, but that's a personal decision. If you follow if you look at a lot of people who are practicing addiction medicine, there's not good evidence that pill counts are helping things. But, again, go back to my rule of what would you do Friday night then?
Do you document at the time of the visit, or do you go back and do it later?
I actually will do a little bit of documentation with the patient, because what I'll do is I'll put my computer like right next to my computer, so I can do both at the same time. But for the most part, I usually just talk to the patient, then I do my documentation right after. These are not going to be long, extensive visits. They usually are not, at least. So documentation is usually pretty quick and pretty easy.
Do you or someone in your office take the time to explain to the patient how the insurance works with telemedicine?
No, what we do is we tell them that we will bill them like we do a normal visit, and if they'd like to pay their copay now, they can, or if they'd like to wait and be billed, they can do that as well.
Thank you.
And again, that's our policy now. It might change a week from now. We're just doing our best to try and keep patients out of the office right now.
Okay. And Dr. Miller says, thank you, Dr. Brown. I agree with you and believe Dr. Still would be especially proud of your efforts for this innovative medical approach.
Well, thank you very much.
Yeah, that's a very nice comment. Okay. Let's see. Those of you that are asking about CME, you're going to go back to the AOA online learning platform. That is where your post-evaluation will be. That is where those going for CME will find the recording. The others will find the recording of this will be on the COVID-19 website. Okay. Great presentation. What about vitals we talked about?
That's really interesting about the Medicare wellness visits. Considering we aren't paid to touch the patient anyways, kind of makes sense.
Mm-hmm.
I'm just reading other people's comments. I appreciate people giving me information too.
Yeah. Okay. She need to be in the office or not at home.
The patient that asked about to confirm Missouri will allow me to deliver telemedicine in your state without any other active state license. That's incorrect. You have to have another active state license, but it doesn't have to be in Missouri.
Okay. What if you don't have a large practice? Do you have any recommendations to start?
Again, just do it simple and easy. Right now, the government said that you can do it with, telemedicine, or you can do it with FaceTime or do this. What I love about this is you can actually do this now very simply and very easily. Before, I'd probably tell someone with a small practice, don't even bother. But now that it's so simple and you can just do it with Skype or FaceTime, sure. I mean, we're all looking for things right now to try and help our patients getting exposed to COVID. Somebody asked 99213 no exam, no vitals. Yeah, I would recommend get a good review with your coders about what it takes to bill a 99213 and learn what it means when you need 2 out of 3 elements. But that is correct. You do not need a physical exam to bill a 99213.
Right. Yeah, you can't bill telemedicine visit if seen prior 7 days, or it ends up having an appointment in following 24 hours.
Yeah. Again, though, those were the older guidelines. I'd have to follow up and see if they're still enforcing that or not. I do know where those guidelines are coming from, but like I said, I don't know if those are if they're still enforcing those ones or not.
Right.
Hopefully when we have the billing lecture coming up here, they'll be able to answer questions like that.
We're hoping.
Someone asked if there's physicians practicing solely telemedicine from home, and the answer is yes, and they've been doing it for years. least the last few years.
Okay.
Someone asked about inpatient. The answer is I don't know anything about that. I will tell you there are lots of groups that do that remotely. And I will tell you, I know, our David Tannehill, our former president of our state, he practices critical care medicine by telemedicine and practices in a center that brings critical care to rural hospitals by telemedicine. So there's ways to do it. I'm just not an expert on it right now.
All right.
Is anyone using telemedicine to monitor COVID patients at home? Don't know the answer to that yet, but I sure would rather do that than have them come in. But as I said earlier in my workflow, I make anyone with a cough or a cold do a telemedicine visit before they come into the clinic. If they have severe symptoms, I send them to the emergency room. If they need to be seen, like I'm worried about dyspnea, but I don't think they need to go to the ER, then I have a special clinic here in our health system I can send them to where we're sending all our respiratory patients. Your hospital will have it or have its own, system for that.
Okay.
Is an iPhone necessary for Skype or is Android okay? The answer is Android can do Skype just fine. Someone said about the modifiers. I'm not the best. I know exactly what you're talking about with the modifiers 2 and 95. I check with your coders on modifiers. I'm not the expert on that one.
The modifier 95 is used more for the commercial carriers.
Yeah, I think, was it 95 or 92?
And the 02 is more for Medicare.
Right. I think the 02 is a location code or something. I don't know. It's we were told specifically by our coders not to use any modifiers on the Medicare codes. But again, that is our hospital decision. And that was based upon their announcement on the waiver.
Mm-hmm.
Yeah. And they are right. The people making the comments, 02 is your location.
Right.
That's just to say you're not in a hospital.
But the GT modifier, I believe that was discontinued about a year ago, if I'm not mistaken. I could be wrong, but I believe.
Someone asked if Skype's easy for the patient and doctor to use. The answer is it's okay. I'll give you a Skype story I had just yesterday, actually. One of my patients wanted to Skype with me, had a really hard time getting his Skype to work. And I said, hey, look, I noticed you have an iPhone sitting right next to you. And I said, what's your phone number? And then I just picked it up and FaceTimed him, and it worked fine. What I've been trying to do is use what most patients that are doing this have already done some kind of video chat with like family members. And so what I've been trying to do is contact them the way they're familiar with. Somebody asked about the personal cell phone number for FaceTime. If you look through my slide deck, I showed how you can use your work email instead of your cell phone number for FaceTime. Very easy to do.
Okay.
I don't know about what app on iPhone or Android, sorry. Not one I've had somebody request.
Yeah. Well, what I am going to try to do, and I will say try, is to take the script of all of these chat questions and try to put them in the order and try to figure out who was answering who. And then I will make sure that all the attendees get a copy of it so that they can, have learned from other people and go from there.
So someone asked if FaceTime was easier than Skype. I think it is but it only works if you have an iPhone, and it's simply because it's built into the iPhone. So if you were to give me your cell phone number right now, I could FaceTime you, and all you would have to click is a little accept, and we would be talking to each other. That's pretty easy.
All right, I've got, let's see.
Someone asked about patients who don't have insurance. What do we charge for telehealth visit? That's one I haven't run across yet in the last week, and that's a great question for me to get answered. So I'm going to go back to my own coders and ask. I assume I would just charge what I charge for a normal visit because I do have a cash pay price. So I would assume I would just charge for that. And the question is, do I get their credit card information first? The answer is, yeah, that's why I have my staff members. I have my staff members do a normal check-in. We're not doing anything different on our electronic health record. We're checking them in just like they were here in the clinic, and that's worked very well for us. I love that lots of people have been giving their suggestions for what video things they've used in the past. I think that's great because there's so many options out there. And if they do make it where we can't use FaceTime again, which may happen, there are some options out there for providers to use. Again, though, it's when you can break down the barriers and make it simple. That's what makes all this stuff wonderful to use.
Right.
It's just simple for the patients right now.
Clarification on that the patient has to initiate.
The answer, so I don't know. I don't know what you're exactly referring to. The patient will have to initiate in the sense that they scheduled the appointment. For me, that's considered initiation. I will then reach out to them directly. But they always have to, obviously they have to tell me how to get a hold of them. So I would consider that patient initiated, meaning that they've called me and given me their FaceTime contact info. They've called me and given me their Skype ID. That to me is the same as them calling me first, or asking me to call them back on that.
Mm-hmm.
Lots of questions about Android. Haven't had any problems with Android because when I connect to someone on Android, I'm using Skype or I'm using FaceTime Messenger or Google Hangouts or something that Android supports. The only reason I like the Apple device is because it adds in that FaceTime, which is proprietary, and you can only get that on an Apple device. And I have a lot of patients that like FaceTime. Again, it's simple.
Asking how prevalent telemedicine is with pediatrics.
I'll tell you, half my patients have been with pediatric patients. They're usually, I just tell them, I'm fine with doing that. Just make sure your mom or dad's sitting right next to you when we do it, and that's what we do.
And then the question, are we seeing you with you using your iPhone, or are you on your laptop?
No, I'm actually on my MacBook right now. So that's a little bit easier than holding for an hour.
All right. Well, I think a lot of these.
Well, like I said, you're welcome to compile them. They're welcome to contact me, or you can send me a list of questions and we can go from there. But good luck with everybody. This is a really exciting time, but I have to say that very carefully. It's also a very scary time for what our patients are going through. Thank you, all of you, for being on the front lines. I know how scary it is not knowing what you're bringing home to your family every day. But that's one of the reasons I push telemedicine, is because it's somewhere where I can be safe as well as the patient can be safe in providing care. And so this is a great way to keep these patients out of here. So, not that I don't want to give care to my patients, but I love doing it at a distance during times like these.
Yes. Thank you again. Could you move the slide one further up?
Sure.
Up. Nope, the other way. Sorry.
That one?
Oh, the one that shows the two links.
These ones? That was back.
Okay, so the top link actually takes us to the COVID-19 page on the AOA's website. The second one will take you to the telemedicine guide. And the AOA online learning webinars. So as far as the billing and coding webinar, we're hoping to get that going next week sometime. And then we've got working on a HIPAA one and a social media. So we have a lot of things in the works, and we're just trying to get all the information we can out to you. If you have any questions, don't hesitate to reach out to the physician services mailbox or phone, and I will do my best to get an answer for you. Again, take a look at our telemedicine guide. A lot of the billing questions you've been asking are available there. Thank you all for joining us. We truly do appreciate it. And a special thank you to Dr. Brown for coming through to our rescue on short notice and putting together a wonderful presentation.
Thank you, everyone. It's been my pleasure.
Thank you.